To conclude this session, we will have a quiz by Dr. Martin Green and Dr. Yash Lokanwala. Over to you, sir.
So, we will be starting this ECG quiz now. We have been given to believe that all of you on your mobiles, you will be in a unique first time we are trying this, that normally we have the voting pads, but this time we are going to vote from the mobiles. And the ECGs are given to you in the form of a small booklet, but I must say they're not very good quality. We have used those same ECGs, but we have jumbled the order. So when the ECGs are projected, we'll give you about 15 seconds to go through the ECG and when the voting is there, he will announce that you can press the voting at that time. At the end, I think we have totally about 19 questions, 19 quiz questions. And at the end of it, we will know which are the mobile numbers which have scored the maximum number of correct answers. Now let me tell you, some of them don't really have only one correct answer, but we as the quiz master, so to speak, we have decided that this is the most correct answer. And that's a sort of license that we have been given.
We do have this license, and we've been happy to take it. The only other thing I will say is, for the last day, we've asked you to put your cell phones away. And for the first time, and of course nobody listened anyway, for the first time, we're going to ask you to take your phones out, and we're going to go over the rules in just a minute.
Yeah.
Dr. Lokanwala will do that in just a minute.
Yeah, we are trying for the first time in cardiac stream, the online or SMS-based quiz event. So it is our very genuine attempt. So please excuse if any hiccups are there. I hope nothing will be there. And there are some 6 exciting awards will be honored. So at the end of the session, the concept is very simple. I'm going to explain you. Okay, just note down that number, all of you. So you can save it as ECG quiz or something. So whatever the questions we are going to display, for that you have to send an answer via SMS. Okay, so the answer format would be the question number, comma, options. So it would be like 1, comma, C or 12, comma, D. That's it.
Capital or small?
That it is case insensitive. You can send caps or small. It doesn't make any difference. And you don't need to send 0, 1. You can send simply 1, 1, comma A, 1, comma B, or 1, comma C, or 1, comma D. And we have all the registered delegates number mapped with the respective names. So if it is not there, we can see your numbers displayed over here. If names are registered, that name will be displayed here again. And all the answers are in the form of objective type here. And the audience shall not give any hints to clues to the other participants. So that is our common rules.
You want to have one trial or some?
No, we'll start with the first question itself. Yeah, see, this is the last rule is very important. So there are some smart doctors will be there, I guess. So they'll be trying 1A, comma, next 1B, next 1C and 1D. Obviously 4 SMS, it will not cost too much. So if you attempt more than once, you will be disqualified. So that answers will not be considered. So these are the small simple rules. So any doubts so that we can kick off the sessions? Any doubts?
Does everyone have the number?
Yes, just note down 9164683374. Yeah, hope everyone will be having the signals. Just store that number, and we will be allotting the time slot. So within 10-15 seconds, depending on the questions, we will be closing the polling section. Yeah.
After each you are supposed to, some will have 4 choices, some will have 3, some may have just 2 choices. Yes.
1 second, I'll answer that. See, once the question is displayed here, the 4 options will be displayed. You can keep ready answers. When we say your time starts now, you can start sending it. Clear? Any doubts? Yeah.
I think we should give more than 10 or 15 seconds.
Yes, sir. Granted.
Make it 20.
Yeah, sure.
No, but we will be describing the ECG in the first sometime, so they'll have that much time.
So we'll say start now, and then we'll tell you when to close.
Yeah, how can I help you? Okay, in the next ISECON, we'll try with that one also.
So you will be saying time starts now?
Yeah, we'll be.
Okay. So you will have some time to go through the ECG while we are discussing the case. So final voting will be 15 seconds, which is good enough. So can we start with the first slide? Yeah, so this is Dr. Green. This is your patient.
So this is a 65-year-old.
Can we have the lights a bit down so that can we have the lights? Yeah, that's better.
65-year-old man presents to the emergency room with palpitation. Here is his lead 2 rhythm strip on the monitor, and we would like you to answer what is the rhythm. The choices are A, SVT, B, VT, C, not enough information. So have a look at that, and we'll start our clock now. So polling is open.
You can start.
Now in Canada, we watch something called Jeopardy, and they play music while you have to put in your answer. Do 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 do.
I think while they're still coming in, let's discuss the answer. We'll start discussing. In the meantime, when you receive all the SMSs, you can tell us, Dr. Green.
So this is a situation where the answer is totally irrelevant, and we've created this really to create, as many of the others, a teaching point, and the answer is really irrelevant. And there's no possible way that you could get the right answer with this, what I've shown you, but that's the teaching point. That's the teaching point. So can we go to the next slide?
Can we go to the next slide?
Or do we have to wait for them to, let's wait for the answers.
Yeah.
Oh, okay. So what you see along the bottom, and I showed you this strip earlier, is the lead 2 rhythm strip that looks like a narrow QRS tachycardia. But this is in fact a wide complex tachycardia, and this is clearly VT when you look at it. So there's no way that you would have gotten this right based on the ECG, and there's no way that I would have gotten this right based on the ECG. The teaching point is that it's not a narrow QRS tachycardia until you've seen the 12-lead ECG. A single rhythm strip showing what looks like a narrow QRS isn't enough to say it's a narrow QRS tachycardia. It's frequent that when you're on the monitor, what you're going to get is a lead 2 rhythm strip. Just to show you, we say this is very rare, you know, it's not a mistake you're going to make. I have a whole collection of these where I've picked out a certain lead, 1 lead or 2 leads, and they are, you know, they show what looks like a narrow. So let's go to the next slide. Just to prove that to you, who here would look at that 3-lead rhythm strip and call that VT? Anyone?
Anyone will say this is VT?
Would you describe that as a narrow QRS tachycardia? Can you hit it again then, Yash? One more, hit the button again.
Click, please.
There's the 12-lead. And if you look at lead 1 or AVF or even, you can see that this again is VT. So I've got a whole collection of these, and I think the message is the same. VT can look narrow. Occasionally VT can even be narrow, but mostly it's wide and it just looks narrow in 1 or 2 leads. So if someone says a narrow QRS tachycardia and they haven't taken the extra minute to do a 12-lead ECG, I think the lesson to be learned is that's not good enough.
And I think, you know, that the couple of situations where this can be dangerous is one is, you know, patients with myocardial infarction in the ICU on a monitor, and, you know, they get this tachycardia or old myocardial infarction. I've seen it happening, and the resident thinks it's SVT and gives verapamil, and they'll end up in hypotension. And the second is recently I got this message, I got this ECG on WhatsApp. of course on my colleague's WhatsApp, because I don't have WhatsApp. And the anesthesiologist sent me that a patient undergoing lithotripsy has developed this tachycardia. What should we give? And it was exactly like this, a single strip taken from the operation theatre monitor. And really it was impossible for me to say whether it was even, forget the type of what to give. I couldn't even make out whether it's a narrow QRS or a wide QRS. So I think the message is, of course, using our quiz master's license, we've given C as the correct answer. There's not enough information. But what does the poll result say? Yeah. Yeah, you can display the answers.
So 70% said A, which is the only answer which is incorrect.
Yeah.
And 16% said C, and only 6% said B, which is the absolutely correct answer. But I think most of us would have got this wrong, and that's the point. And most of us did. 70% got the only incorrect answer because we didn't follow the process. The process, you have to look at the ECG. So there are people here who say they voted and
I think we are having some hitches in the message going. Are you having signals? Are you having signals? So it will come later then. It will come as the correct answer later. This, from next time onward, we won't stop. We'll just go through the quiz.
We've never done this before.
The messages will still be coming in. Don't worry, they'll come in. They're still coming in. So far amongst the messages that have come, 4 are correct. Okay, next, can we go to the presentation? So this is an ECG of a 25-year-old gentleman. Yeah. No further history is required. There's a lot of computerized diagnoses made. And I'll read them out. It says atrial fibrillation, rapid rate, right bundle branch block, VPCs, right axis deviation, LVH by voltage, lateral infarct, inferior infarct, age indeterminate, tall T waves, query metabolic or ischemic, and the last thing it says is T wave abnormalities consistent with ischemia. So the question is, do you agree with the computerized ECG diagnoses? A, yes, completely. B, only partly. C, not at all. And D, it's a stupid question. You should not be looking at the computerized diagnosis at all. So you can start sending your SMS now. Okay, all of you have sent. Anybody left to send it? No. Fine. So can we go back to the presentation? Dr. Green, I want you to take us through each of those computerized diagnoses and tell us, is there any one of those that you agree with?
What a silly question. Who looks at the computerized diagnosis anyway? So everything about the computerized diagnosis is nonsense here. It's obviously it's a irregular wide QRS tachycardia. Anytime you start talking about repolarization with this rhythm, it basically the repolarization becomes meaningless when depolarization is so abnormal. So did you want me to say what I think the rhythm is? Or are you going to do that?
Yeah, anyone in the audience, what is the correct diagnosis? I'm sure most of you know it. Yeah, it was just covered in the previous lecture by Dr. Shashidhar. It's fast, broad and irregular. So there is only one diagnosis, that is atrial fibrillation with Wolff-Parkinson-White syndrome.
I think that's critical. People yelled out Wolff-Parkinson-White, but the rhythm here is atrial fibrillation. And it's pre-excited atrial fibrillation, but the rhythm is actually atrial fibrillation. Irregularly irregular, think atrial fibrillation.
It's amazing. I mean, this ECG, this type of ECG is shown in probably every quiz. And yet, in actual clinical practice, more than half the time I see this is diagnosed as VT, which actually is not bad because sometimes the treatment is the same. Can we go to the next slide?
It's bad if they've gone to an ECG course.
Yeah, so go to the next one. Doesn't matter. So the next slide is related to this. So you've diagnosed atrial fibrillation with WPW syndrome. The patient is in front of you. He's obviously not doing well with that rapid rate. So what to do immediately? A, do nothing. This normally settles on its own. B, give IV adenosine. C, give IV amiodarone. And D is shock the patient. Is D. A, B, C, D. So 4 corresponds to D, the 4th letter of the alphabet. So you can start sending your SMSs. I think we'll, at the end of the quiz, say who got what. Everyone sent their SMS? Anyone remaining? I think all of you have sent your SMS. Okay, we stop receiving the SMS. Okay. So I think here this should be pretty straightforward. You obviously cannot give adenosine for this because you can actually trigger off ventricular fibrillation. You'll block the AV node, and post adenosine, you know, there's a lot of sympathetic drive. So you'll actually increase the ventricular rate, increase the ventricular irritability, and it could be a disaster. You obviously, amongst the antiarrhythmic drugs available, amiodarone is safe in this setting, but it's not promptly going to act. So the best treatment in this very nasty arrhythmia, you want quick restoration of sinus rhythm. So the best is to give a synchronized DC shock with adequate sedation. And that's pretty straightforward. Can we go to the next one? So this patient was cardioverted, and you saw the classical short PR, delta wave, WPW pattern. Next slide. So what should be the long-term management? What's the best long-term management? Again, I think it's pretty straightforward. The key is what is the best option for this patient. A, RF ablation. B, beta blockers. C, verapamil. And D, long-term oral amiodarone. Sorry? No, not. Question is, forget 2B. Which choice? Question number? 4. Oh, we have to go to the presentation. Yeah. Question number 4. So 4, A, B, C, D. Okay, so we have all the last 3 seconds to go. And I think this is, so we stop the polling. This is a very straightforward, clear-cut example, which is what we call as a class 1A indication, an absolute indication for curing the patient by RF ablation. The patient has already had one life-threatening arrhythmia. You don't want to wait for the next life-threatening arrhythmia, especially when something which is curable by an ablation procedure with high degree of success and low chance of complications and recurrence. So the correct answer is A, RF ablation. When you go back to the presentation. So now from these straightforward cases, we start moving to the little next. Okay. So Dr. Green has this one, and can you...
Could we see the answers on those ones? No?
No, do we have we received all the SMSs for the previous one? They'll keep on going. I think they'll tell us later on.
Okay. The only reason I ask this is because if we find there's a lot of discordance in the answers, we might want to concentrate a bit more on the top. We can go back and do it then. Okay.
Okay.
So this is a 50-year-old man, and the question is, what is the rhythm? Is this heart block? Can we see the presentation so they can see the ECG a little bit better? And the possibilities are yes or no. Is this heart block?
It's question number 5. It's question number 5. Yeah. So 5A or 5B?
So the polling is started.
Polling started? Yeah. I think this is interesting. I think this is a simple concept, but most of you should be clear at the end of this slide. 5A or 5B? 5, A, 5, B. I think Dr. Green, you want to discuss this?
So this ECG shows an atrial tachycardia with 2-to-1 conduction. And we talked about this earlier today. 2-to-1 conduction rather than 2-to-1 block. So it is normal when you have an abnormal atrial rate for the AV node to block impulses. In fact, if we put any of you on the EP lab table and paste your atrium, we would get Wenke back and then 2-to-1 block. It's a normal physiologic response. So we do not call this 2-to-1 block, we call this 2-to-1 conduction, and it doesn't really fit in the classification of heart block. So I think the correct answer here would be no, this does not fit with heart block. Did you want to add something else, Yash?
No, I think so. It's important because many times people say if a patient comes with a tachycardia and you say the atrial flutter with 2-to-1 block, it doesn't make sense. The patient is having tachycardia. You talk about block in bradycardias in disease of the conduction system. This is a normal behavior of the conduction system. Any self-respecting AV node will filter out some impulses if it's so fast. So this is not heart block. Next slide.
So we do get patients referred for heart block with this type of arrhythmia. So you can see here the P waves, the second P wave on the back end of the QRS in the ST segment. So this is atrial tachycardia with 2-to-1 conduction. It is a normal AV nodal physiology to have 2-to-1 conduction. This is not heart block.
So you have this in the booklets with you. It's not seen so well here. Can we go to the presentation? During polling, we'll come to this. Yeah. So this was a 62-year-old lady with incessant tachycardia. When we switch to the other screen, that means we start the SMS. Structurally normal heart, who was euthyroid, and incessant. The term incessant means you're having tachycardia at least 12 hours in a day for several days at a stretch.